So we're going to change gear now, and I hope that the panelists will stay with us if possible. If you have to go, that's fine. But we're also going to invite Philipp Lurz to come and join us on the podium, because we're going to expand our discussion now. Philipp, here you are on my left. So we're going to expand our discussion now into the field of mitral and tricuspid interventions for the last 20 minutes or so. And if we could return to my slides, and I'll just present them here from the main desk. So we know that the aortic valve, despite the extensive hours of discussion we have about it, is a very simple valve, whereas the mitral valve and the tricuspid valve are far more complex in their innate anatomy, and importantly, their relationships to the left and right ventricle respectively. We also know that similar to aortic stenosis, mitral regurgitation and tricuspid regurgitation, regardless of the etiology, is associated with adverse clinical outcomes over long-term follow-up, as demonstrated by these serial Kaplan-Meier curves. And perhaps the most important message of all is that for several years, if not decades, we have been systematically underserving our patients by providing restricted access to life-enhancing and life-prolonging interventions, be they by means of surgery, timely surgery in the form of mitral valve repair, and increasingly access to transcatheter techniques, particularly in the field of secondary mitral regurgitation beyond medical therapy and CRT for carefully selected patients. These realizations were brought forward and highlighted very prominently by the guideline publications in both the US and in Europe, adopting a more liberal, a more stronger level of recommendation regarding the use of transcatheter interventions. And of course, we have an increasing array of techniques and devices available to us to offer to our patients year on year. So in the next 15, 18 minutes or so, we're going to focus on this topic area. Firstly, we're going to turn to you, Philipp, to provide us with an overview from the lectern, if that's possible, of the currently available interventions for tricuspid valve regurgitation. Philipp.
Yeah, thank you, Bernard. It is my pleasure to present to you what's being called the Edwards trilogy of different transcatheter approaches to treat tricuspid regurgitation. Now, first of all, I would like to remind ourselves that the reason for tricuspid regurg in the vast majority of all the patients we see is annular dilatation. And one of the very few devices which actually tackles the reason and the cause and source for tricuspid regurgitation is the cardioband system, the transcatheter approach, mimicking the surgical annuloplasty, implanting a band to reduce annular dimensions. And we've seen the results of the TRIBAND study proving that with this approach, as intended, annular dimensions are reduced, and this then leads to a marked and significant reduction in tricuspid regurgitation. So this is an approach which is not just dealing with the consequence, but the actual cause of tricuspid regurgitation in the vast majority of patients. Then we move on to something which became already one of the workhorses of transcatheter tricuspid valve approaches in clinical routine, the Pascal system for edge-to-edge repair. That system has several specific features, which includes a central spacer, the ability to elongate the system when maneuvering in very dense cords, and it is nitinol-based, which is a very important feature because it's quite flexible with a passive closing mechanism and the ability to perform independent leaflet grasping. And we see the results of the CLASP TREF study showing that almost in 90% of patients, TR could be reduced by at least 1 grade. This is, I guess, how we started off, but we want to do a little bit better and we want to perform better. So now we have a new treatment goal, which is bringing it down to moderate or less. And we here see that at 6 months, that was achieved in 78% of patients. And that is also confirmed by reduction in quantitative measures. We now look at another analysis using the Pascal system to treat TR, 8 tertiary centers in Germany, confirming these results with a percentage of 77% of patients with moderate or less TR, and this resulted as expected, and that's the reason why we treat these patients, in a symptomatic benefit with a significant improvement in NYHA class. And then lastly, a sub-analysis of that cohort looking at specifically at the Pascal ACE device, which seems to be the default device when treating tricuspid regurg, as compared to the larger Pascal device. Again, here, very promising results, 86% of patients with moderate or less TR after the procedure. And then finally, something which certainly can be considered as the future, but it also becomes to be the presence more and more, which is tricuspid valve replacement. Very exciting and very thrilling data from the EVOQUE TR trial. What's so important is that it's the only way to not only reduce TR, but abolish it completely in the vast majority of patients, as shown here, and again, very encouraging 6-month data with almost no patients with any significant TR left afterwards. So much more to see, rapid development in the field. A few years ago, we had nothing but diuretics, so we are in a much better position now, and there are more discussions in this session tomorrow. Thank you.
So thank you very much, Philipp. A nice, concise presentation of what's available to the interventionist. But perhaps we should ask a surgeon, first of all. Hendrik, what's been your reaction to this surge of interest in the tricuspid valve that's sat quietly in the clinical background for so many years?
Well, it's very good that we tackle this problem because it's an imminent problem for many patients and they suffer a lot from TR. So it's very important that we have something going on, and not everybody is a good candidate for surgery. Although, since you asked me, Bernard, so it's also my pleasure to have a look at the surgical perspective. There are surgical techniques that also tackle the problem quite well. And we can do minimally invasive beating heart surgery, and that has much better results than we've seen in the trials before that reported like 10% mortality rates. So it's not that this is the end of the story for surgery. I think we should also, as surgeons, tackle the problem in a different way, and we are about to collect all the data on that now. And I would love to see in the future, and I would love to also hear your opinion on that, should we have this as another comparator in the trials going on, not only to compare interventional therapy to best medical treatment, but also to minimally invasive beating heart surgery as another competitor in the field. I would love to see that.
I agree with you entirely, and we should remind ourselves that the guidelines have also encouraged surgeons to take a very aggressive approach to the tricuspid valve, not just interventionists with new tools. So not only at the time of tricuspid surgery, but also at the time of mitral surgery to address preemptively the later problems relating to the tricuspid valve. Philipp, you've probably got the most experience in this room of tricuspid valve interventions. Are you treating, by and large, patients who are not suitable for surgery?
That's certainly how we started off. So at the beginning, we treated almost all of our patients were inoperable. But with the application of these techniques, I guess that we also created awareness. And we see a change in patterns of patients who are referred to us. They're referred now earlier. They are referred at a stage where some of these patients have an increased surgical risk, but not prohibitive. And that's one of the prerequisites if we want to, at some stage, actually do a comparative analysis comparing transcatheter and surgical approaches. So irrespective of all devices, one of the great things which happened already is awareness for the disease.
And are those trials planned, the ones that Hendrik is calling for?
I'm not aware of a trial which is in a state where it's worth talking about.
Okay, that's a very diplomatic response. Phil, have we got anything from the chat at this stage?
Well, there's just some discussion about the role of NYHA classification in right heart failure, and I think it taps into perhaps an increased awareness of the way we assess the right heart and also assess the tricuspid valve. We're now very interested in the tricuspid valve, and we're all showing an interest, but I think we're sort of starting again in terms of how to assess these patients, not only from their symptoms, but also from exercise, physiology, echo parameters, and various other things. So there's some discussion about whether the NYHA classification is the right classification to use for tricuspid regurgitation. There's no answers here, though.
Comments, Philippe?
Well, from a scientific point of view, obviously it's a little bit difficult because you have placebo effects and so on if you have just a case control study. But one thing I'm absolutely convinced of is that tricuspid regurg causes shortness of breath. And these patients, they do present in NYHA classes 3 or 4, and they do get better, and they have a lower NYHA class. So the belief that this is just a symptom of left heart failure is not something I observe in my experience.
Yeah, and we all recognize that having grossly swollen legs and being fluid overloaded all of your life is a very miserable way to exist. Even if an intervention doesn't make you live longer, at least you can feel better for the last years of your life, which is a very valuable endpoint. Just one quick question from me, Philippe. Where are we with the EVOQUE in Europe, with the CE mark and so forth, and its expansion across the geography of Europe?
Yes, so I'm very excited to be part of the EVOQUE pivotal trial, which is a trial performed in the US, but also some centers in Europe. And this trial already entered the next stage, comparing tricuspid valve replacement with conservative treatment and looking at heart clinical endpoints. So this is a major step in evaluating the influence and clinical significance of these therapies when it comes to heart clinical endpoints.
Okay, fantastic. So we're galloping on now to the mitral valve, and we're going to call on Fabien to come back to the podium and tell us about the application of the Pascal device in the mitral anatomical position. Fabien.
Thank you, Bernard. So yeah, we go to the mitral valve, and that's one of the advantages of this system that can be used on both sides with actually the same or the similar technique. So Philippe has mentioned this already. I don't come back in detail on this. I just want to mention that the structure of that device is a bit particular because it's a nitinol device. So you have two sides of it, and the spacer in the middle, and the sense of it is really to reduce the tension you put on the leaflet and be automatic and physiological in the way the mitral valve or the tricuspid valve is approached. So on the mitral, the same story with the big Pascal device, the larger one, P10. So I mentioned this study, which is going on in Europe, so including a consecutive patient treated with the Pascal device on the mitral side. And there are some primary results we show here for the first time at PCR London Valve with 200 patients included. And what you can see is a very good reduction of mitral regurgitation severity with about more than 80% of the patient having mild mitral regurgitation after 30 days. And you see also a signal, it's a trend toward reduction of left ventricular and diastolic volume, which is always, after treatment of mitral regurgitation, a very good signal. If we look at comparison with MitraClip, it's an observational study, but you can see that both devices are at least on the same level in terms of reduction. We are now aiming at mitral regurgitation grade 0 or 1, and you see that these devices are doing very well, in particular Pascal with almost 90% or 87% reduction in the very experienced center to grade 0 or 1. What we can also see, and that's probably a consequence of the particular design of the device, is after release, after you release the device, you see in some of the MitraClip cases an increase of mitral regurgitation, and in the Pascal device actually a more stable reduction of MR that you can really observe in practice, and that's probably also the consequence of the difference in terms of tension on the leaflet. If we look at other indicators, we see that the MR reduction in the CLASP study is very sustained. We also have this signal in the CLASP study regarding reduction of left ventricular end diastolic volume, and of course the corresponding improvements in exercise capacity. Mortality is quite low at 2 years. You see that in average 80% of patients are still alive, and you also have a good reduction of rehospitalization, which corresponds to a good quality of that therapy. So if you want to learn more about this device, there will be another session on Tuesday about more technical issue with the use of the Pascal device. Thank you very much for your attention.
So thank you, Fabien, and thank you for providing that talk for us. One of the major advantages when it first became available was the concept of single leaflet clasping, and of course other devices now have that modality, but as an experienced mitral valve repairer, if I can put it that way, does single leaflet grasping or clasping make a big difference to the execution of the technique?
You know, I think Philipp will confirm as well. We are now really used to using that technique. So the Pascal device was the first one to propose this single leaflet clasping, and that's something we are doing now on a regular basis, not to grasp one leaflet and then the other one, but rather to be able to optimize the grasping. So what you do typically, if you're not completely happy with the grasping of one of the leaflets, then you reopen selectively on one side and optimize the clasping of the leaflet. And sometimes you really see a further reduction of mitral regurgitation just by doing this maneuver that can be really safe.
Agree with those comments, Philipp?
I totally agree. So the independent grasping is not there to be sloppy and get one in first and then the other, but again try to grasp both leaflets simultaneously, but then use it, as Fabien expressed, as a single leaflet optimization. Yeah. And it's worth to be very accurate, then you achieve the results as presented.
And just linking back into the tricuspid arena just for a moment, I know that the single leaflet approach there, in my limited exposure to tricuspid interventions, it does make a big difference.
There we have much larger gaps, and then sometimes we can't do a simultaneous grasping to start with. And there it is obviously a very useful tool to get one leaflet in first and then swing over to the other to bridge larger gaps, as we often see in these patients.
Phil, anything from the chat?
Just one important comment from Maurizio Taramasso, that because of the flexibility of the Pascal system, there's more predictable result before clip release. And so I think he's making the point in the chat that with the Pascal, you don't get any surprises when you release the clip. Whereas with a more rigid delivery system, you might feel you've got a good result, release it, and you get a different dynamic movement of the clip once released. So I think it was an important point.
And one thing that we missed in the TAVI arena and the development over TAVI many years was head-to-head trials. So I guess an inevitable question is, will we see head-to-head trials comparing the mitral valve repair technologies? Are they going to be led by major centers independent of industry? What can we anticipate? I'm looking at the key exponents here. But Fabien.
There is already, Philipp knows that, there is already one head-to-head device trial running, and in the two etiologies, so in DMR and the primary and secondary mitral regurgitation, at two separate arms to really compare the performance of the device in both etiologies. So that's already running, but there may be additional one coming in the future.
Okay. And is there a surgical arm? I have to include Hendrik.
No, not in that trial, basically. But I think we will see trials where we compare interventional therapies to surgery, and there are trials now at least for the mitral clip that I know of that compare that with surgery. I'm not so sure about the Pascal system, if there's something planned, not yet maybe, but would be a good idea actually, especially when it comes to primary MR, of course.
Absolutely. Okay, so unless there are any further questions from our online community, Phil?
There is nothing else.
Okay, so just a few concluding remarks. So just to let you know, I will need to see the final slide that we had from my original deck for Phil's benefit in a moment. So we'll come to that just now. But just to thank everybody for staying with us late into the evening. We've had a very wide-ranging discussion regarding aortic valve disease guidelines, optimal surgery, optimal TAVI, new techniques and tools available for mitral and tricuspid intervention, and we've certainly addressed many, many important clinical and patient-related questions. This is merely part one of a two-part series of sessions, and tomorrow morning Phil and I will be back with you, not at too early an hour, I'm pleased to say. But Phil, tell us what's in store for tomorrow morning.
Well, so we're going to continue the theme of optimizing procedures and optimizing the patient journey. I think all the themes that we've touched on today, which are quite wide-ranging, we're going to continue to completion tomorrow. So I look forward to seeing everyone there. Okay, so the message is don't go to bed too late, and we look forward to seeing you tomorrow morning. Thanks very much. Thanks, Bernard.